Good morning, everybody. I welcome you to the first ever virtual ASSICON 2021. And I assure you that this is going to be a hell of an experience because we've got a galaxy of stars with us. We've got more than 30 international faculties from all over the world. We've got the best of the national faculty lined up for you. So without wasting any more time, I'm going to introduce you to the moderators of the first session. It's my proud privilege to welcome Dr. Raj Shekharan, sir. Welcome, sir. Good morning, sir. And Dr. Shailesh Hargaonkar from Pune, who's the young dynamic surgeon. Over to both of you for the proceedings of the first session.
All right. Thank you, Ankur. I would like to, it's a great privilege for me and Shailesh to be moderating the first session of the ASSICON. As you rightly said, COVID threw a lot of challenges, but also a great number of opportunities. And they say when the going gets tough, the tough gets going. I think this was precisely what happened to ASSI. I should congratulate our President Chabra, Secretary Ajay, and Ankur, Gautam, and the whole team for doing this excellently well. And we have a fantastic team over here. And this has given a great opportunity. As you said, 30 eminent foreign faculties. And how else we could have done other than this being virtual. So we'll start off with something that is very debatable and also of current interest on navigation. Technology is invading spine surgery like anything. And to do this, we have two of the very eminent people who have published a lot, people who have experience maximum on this field, and David and Neil and Masato and Munish, four of our great friends of not just me personally, but for entire India, for ASSICON, for ASSI. Thank you for being with us. And we will start off with the first talk. And David, congratulations for being the opening batsman for ASSI this year. I would invite David to give his talk on navigation in spine deformity, pearls and pitfalls. David, over to you, David.
Thank you. You can go now.
Hello, this is Dr. David Pali. Greetings to my friends in India, and may you have a wonderful meeting. I'm sorry I cannot be with you in person and hope that the world returns to a place where we can travel and be together physically again soon. My disclosures. This is my practice. I do pediatric and adult deformities such as this idiopathic scoliosis, this congenital kyphosis, adult scoliosis, severe adult deformity, and I utilize navigation quite a bit. I utilize it to place pedicle screws in very small pedicles, such as in this neuromuscular scoliosis patient. And that with this navigation technology, we use the tap to help us determine the diameter of screw that the pedicle will hold as well as the length. And then we place the screw and check virtually, and oftentimes perhaps about 1% of change based on it. Here's an actual case. This is an adolescent idiopathic scoliosis patient. This is real-time video utilizing an overhead camera along with the navigation screen to show you how long this takes us to place the screw. We've identified the start point. I utilize a burr, create a cortical defect. Now I'll take a navigated awl, insert the awl through the pedicle. Typically, we mallet this end. If the pedicles are small and sclerotic, then we'll use a drill. Various people have various preferences for which technique they use, and I think there are many ways that this works well. So from there, we will remove the awl and then place a tap. If your assistant is helpful and docks this in, then it goes a little bit faster. And then we will upsize the tap to judge the maximum screw diameter that we can place. Then the tap is removed. The size of the screw has been given to the tech, who then loads it, and now the screw is placed. And I do like the tactile feedback that comes from placing this by hand. Certainly it can be done by power, but I think there is less tactile feedback. So this is that patient. So it took about a minute and a half to place the screw from start to finish on that particular. So why bother? Well, we know that deformity alters normal anatomy, and we put in a lot of screws in these deformity patients. The pediatric patients may have more challenging pedicles, especially in the concavity of the curve, and that if we can avoid a neurologic event, then we certainly want to do that. That the data says that if you place 22 screws in a patient, that you will often have one malpositioned, and that we're also looking for stronger screw purchase as we apply greater forces to these screws, so we need to optimize them. And that I've had a zero return to OR rate for screw malposition with navigation, but I do reposition somewhere in 1 to 2% of screws in. One of the key understandings is understanding the insertional arc. So in this patient with a previous fusion for scoliosis who had flat back syndrome and needed a revision, we can look at this trajectory as a perfect trajectory through the L1 pedicle through the fusion mass. This is out medial and this is out lateral. That's a fairly narrow window to achieve with other strategies. We know the morphologic distortion that occurs in the pedicles as this is studied and more published. We also know that the pedicle morphology varies and that we commonly are placing screws in type C and type D pedicles. So how good is good enough? Is 100% accuracy an achievable goal? And what is an acceptable rate of malposition or complications? And then what amount of OR time or radiation is justified in order to avoid these problems? So there have been multiple meta-analyses on this topic. And that when we look at the initial one, this is what drove me to understand this a little bit better. And that if we look at the box plots, we see that navigation improves not just the accuracy, but also the overall spread of accuracy in patients undergoing this technique. And that in looking at pediatric pedicle screws, an SRS group effort analyzed the literature, and it shows that navigation does improve accuracy of placement. Cases. This meta-analysis shows that navigation decreases the screw perforations in the thoracic spine and in the lumbar spine, and that the operative time was no different. Blood loss actually was less with navigation compared to with, and that for every 11 screws placed, it prevents a perforation, and that the clinical implications of these perforations range from inconsequential to catastrophic. In a study out of the Children's Hospital of Pennsylvania, they compared surgeons who used navigation to those who didn't, but all of them did a check spin of their imaging of their pedicle screws at the end of the case and showed that the rate of screw removal was much lower in the navigated compared to the non-navigated cases. There are a series of potential sources of error in navigation, and this is from my experience rather than from the literature. So all navigation requires some sort of reference frame attachment, and that this can be bumped or dislodged, especially with the passing of surgical instruments. And if the spinous process is not robust, then this makes it difficult. And I found that in my young congenital patients, this is often the case. Intersegmental motion affects the navigation accuracy, and so I try to place my screws first before doing any osteotomies or releases. It is possible to deform the instruments themselves, so we've bent multiple awls. There are system errors, but these are usually pretty rare. and that this can be checked by comparing a known point, such as the tip of a spinous process 2, 3, 4 levels away from the reference frame, and that gives you a accurate assessment of the real versus virtual. We did a study comparing the accuracy of real versus virtual, and it's 31 patients, 240 screws. About 1.5% were revised based on the check spin. It showed that a mean angular difference between virtual and actual is about 2 degrees. So we tried to represent what does a 2-degree variation versus other degrees of variation look like, and 2 degrees in general should probably be pretty acceptable. How about clinical series? Noel Larson looked up our series from the University of Minnesota, and this was our first cohort. So this was our learning curve as well as subsequent patients. So it's about 2,500. We had a 2.5% repositioning rate, greatest in the mid-thoracic spine, and there was no difference between adults and children. But that our data shows when we look at the pedicle size, once the pedicle is smaller than about 4 millimeters, we see that there was an increased rate of screw malposition. Again, our return to OR for this has been 0, in part because we do a check spin. And when I try to find in the literature what is a return to OR rate for malposition screws, it ranges from 0.8 to 4.3%. How about in congenital deformity? Again, Noel looked at our case series, and we had about 14 patients. And that one of the interesting pieces for me, I tend to be a 2.0 screw density, so placing pedicle screws in each available pedicle. And 19% of the time, there was no pedicle present, so that was a 19% dropout rate, and this was not always evident on the plain films. How about percutaneous instrumentation? So our group looked at this comparing open to percutaneous in terms of impingement on the facet, and that what we showed compared to the literature, navigated percutaneous screws had less impingement or facet joint violation compared to non-navigated percutaneous. How about radiation concerns? This is appropriate and real, and that one O-arm spin on standard settings is about 35 seconds of fluoro equivalent, somewhere in that ballpark. There are a lot of other ways to look at it from a radiation physics perspective, but this gives you a overall ballpark sense. So in conclusion, navigation results in more accurate screw placement. There is not evidence that it takes longer, results in increased blood loss, or that it changes complication rates. It does require capital investment, and there is increased radiation exposure to the patient, but probably decreased radiation exposure to the team. So my personal experience in more than 11 years of using it, and it's actually longer than that now, is a 0% return to OR for screw malposition. Our time is, as you saw, about 2 minutes to 3 minutes a screw. If you miss a screw and have to redirect it, it takes a little bit longer, and revision screws take longer than primaries. It's enhanced our institutional ability to accurately place percutaneous screws and has allowed highly reliable iliosacral implant placement. So I just want to show one example of where everything doesn't go perfectly. So an AIS case, placed screws in the bottom, the reference frame up, placed screws in the top, and then our check spin showed that we did have a medial perforation. This was subsequently redirected, and no neurologic sequelae, and the patient has long-term. And here are her first erect. So it's not perfect. I believe in trust but verify. There is increased radiation exposure to the patient and decrease to the team, and you need to do what's right in your hands for your patients. And for me, that's navigation. Thank you very much.
Yeah.
Shailesh, go ahead.
Yeah, excellent presentation, Dr. Pauly. I would like to ask about your experience as you're doing it for so many years. One paper by Jung et al. Has mentioned that when you start your navigation and OARM, there are 60% chances of having some error. In the second phase, it is 40%. And once you become expert, then it is very good. What is your experience about this cruise with navigation?
So it does require a commitment to understanding the technology and using it well. So we made a decision when we started using OARM in the fall of 2006 that we would use it on cases where we didn't really need it, so that when we had cases where we really needed it, that we were used to it and it was just a part of our workflow. So we adapted that as a cultural behavior pattern in our institution. And it became such a routine thing that it wasn't a big disruption to the OR workflow. And so we just sort of do it the same way every time. And with that, we've just not had that challenge. We did go through a learning curve and getting the technology right in terms of having the scrub techs and the navigation person running the navigation unit getting used to our workflow. And that sped up over time. But we also made the decision that we were going to do a check spin to confirm our accuracy. And you can see that we've had a consistent about 1% change in screw position rate throughout our time. And we've not had neurologic sequelae due to screw position. We have the standard neurologic challenges of 3-column osteotomies and big deformity corrections, but we just have been much better in our screw placement. The screws are bigger and longer. And when we're doing scoliosis corrections, we've been able to put a lot more force on the screws. So our experience would not reflect the experience of the study you suggested. And I can't tell you exactly why that is, but we're very comfortable using it. We all sort of use it in the same way. And it's just how we do business now. And it works safely in our hands. So.
Very well said, sir. There is one question in everyone's mind. Whatever the papers are coming up, they are talking about the cortical breaches, and the types which they have mentioned is 0 to 2 millimeter, 2 to 4 millimeter, and more than 4. In routine practice, how much it really matters if it is a 0 to 2% breach?
That is a really, really good question. So that study goes back to Stan Gertzbein and the SRS fracture study in 1990 that was published in Spine. And what Stan said was that in what they looked at, they did not see any sequelae from 2 millimeter screw breaches. This was more of a fracture patient population, much more at the thoracolumbar junction. What I would say is Linke has taught us now the morphologic changes of the spinal cord in the concavity of a scoliotic deformity. And when you have spinal cord shape deformation, any breach can be profoundly problematic. So I think it depends on what the setting is and what you're looking at, and that it depends on what region of the spine. So I think we all want to shoot for 100% accuracy. Some of the time we have violations that are not problematic, but I don't know anyone who wants to have violations. And that if we're going to have a perforation in general, we would prefer that it be lateral to medial. And the biggest danger zone is the apical concavity of a big scoliotic deformity where there isn't much room for error. And so I guess that would be my response, having looked at this over the years. So.
Okay. Yes, Raja sir, what is your experience?
I mean, we, as David said, this is the way we run the business now. I mean, I would be really very uncomfortable in doing any major osteotomies or difficult deformities without navigation. There have also been instances where when we had severe neurofibromatosis and deformities, if there was a hitch in navigation, I would actually postpone the surgery by a week to get that right, because the difference of comfort of operating, your ease of operating, your accuracy is huge. when you actually come to difficult deformities. So I think we are actually running late by 5 minutes already. So we should move on to Professor Tanaka. It's been a great pleasure to always know Tanaka. I always get enthused by his enthusiasm, and it's great fun having him in any of the conferences. So Masato, can you please go on with you?
Yes, thank you. Good morning, dear colleague. It's a great honor for me to attend this wonderful meeting. Today, I'd like to share our knowledge about spinal navigation with you. For MIS, spinal navigation has several advantages, such as less radiation hazard to the staff, no guide wire complication, and we can use 3D image. On the other hand, there are several disadvantages like equipment is very expensive, navigation error, and learning curve. We have OARM. It needs few seconds to take a clean image. Various kinds of navigated instruments and implants are available, like navigated high-speed bar, navigated cork, navigated expandable case. This is the topic of my talk. First, I'll mention about cervical application. This is a conventional use of navigation for Down syndrome. Now you can see the atlantoaxial subluxation. Here is a video. After the exposure, use O-arm. Now I'm putting C2 pedicle screw. C1 lateral mass screw is also inserted under navigation. This is post-op image. Screws were inserted correctly. This is a cervical OPLL case. Now you can see the double layer sign of OPLL. This means a high risk of dural tear. We reported intraoperative O-arm navigation guided OPLL floating technique. There is no reliable structure suitable for reference frame around anterior neck. If you attach the reference frame to Mayfield or table, these are very mobile, so navigation accuracy is not so good. In our technique, we attach the reference frame to the retractor with a special connector. Remove the vertebral body with high-speed burr. Use ultrasonic bone cutter. Finally, OPLL is floating. Let me introduce our new technique, C-arm-free biceps, minimally invasive cervical pedicle screw fixation. This is a postoperative approach to the cervical pedicle. Cervical lordosis enables us a very small skin incision. Just 4 cm paraspinal incision leads the facet joints. Put pedicle screws. Neuromonitoring is preferable for this technique. This is post-op X-rays. These are CAT scans. According to our results, over time and blood loss are less than conventional technique. Next topic is thoracic application. Nowadays, for AIS, posterior procedure is very popular. Why do we need anterior procedure? Because we can save one mobile segment for patient. This case is 13 years old female, Lenke type 5. Let me show you the video. Screw trajectory and lengths are measured on the screen. Then tapping with navigation. No CM needed. Finally, put a screw. In Japan, dual rods technique is very popular. This is a post-op X-rays, already published. This is the upper thoracic OPLL case. You cannot decompress spinal cord from anteriorly because of the large vessels. For this case, we perform a new technique of posterolateral decompression of OPLL with navigation. Cut the intercostal nerves and elevate the spinal cord gently, then make OPLL floating from posterolateral. We make 2 gutters correctly from posterolateral and make OPLL floating. This patient got the full recovery. The new technique of transdiscal screws for dish fracture. The position of the patient should be lateral, not to open the fracture site. These are post-op X-rays. These are post-op CAT scan. If you use this technique, screw pull-out strength become 1.6 times more than conventional PPS. So 2 above 2 below fixation is enough even for dish fracture. This is the revision case of balloon kyphoplasty. Just a small 5 cm skin incision, then remove a rib. Use navigated curve, trial, cage. Expandable cage is also navigated. These are post-op images. Take-home message. Could you remember MICEP's minimally invasive cervical pedicle screw technique? Position of the reference frame is very important. CM-free anterior correction for AIS is a novel technique. Pull-out strength of transdiscal screw is 1.6 times more than conventional screws. Final topic is lumbar application. This is L3 and 4 spondylolisthesis case. We performed a novel MIS technique of simultaneous OLIF and PPS. One surgeon is inserting PPS at right 5L pedicle. Other surgeon is using navigated curve. Finally, a navigated cage is inserted simultaneously. This reduces OR time. These are the post-op. OR time is just 1.5 hours. Every screw and cage is inserted correctly. If you use simple position technique, you can reduce OR time by 30 minutes because no need to change the position. If you use this simultaneous technique, you can save more than 1 hour. Let's move on adult spinal deformity. We have a lot of this kind of patients. If you use lateral approach and ponteostomy, you can correct this deformity. However, this is a big surgery for elderly patients. I'm a big fan of Professor Anand's concept. We modified his idea to CM-free technique. As he recommends, first OLIF, then the second surgery should be chosen. It can be open or PPS. If curve angle less than 30 or PI minus LL 25 degree, we choose PPS only. All procedures are performed without CM. After draping, use navigated instrument including shaver, curve, curette. Then finally, the navigated cage is inserted. Recently, L5S1 olive cage is also inserted in the same lateral position. They have a fantastic retractor, no C-arm. This cage is a hyperorthotic cage, and ALL should be cut, so it's a kind of anterior column release technique. 1 week later, posterior surgery. More than 50% of total cases are candidate for this circumferential MIS. Now we are putting PPS. Post-op X-rays. Deformity is nicely corrected. If vertebrae are fused, it's a contraindication for MIS. Usually, we need posterior open osteotomy for this patient. In this case, CT shows L12 vertebra and facet joints are fused. We perform navigated lateral osteotomy for this patient. These are post-op images. CT scan. Lateral osteotomy was done, and we could get a good correction. Take-home message. Navigated expandable cage is excellent. Simultaneous OLIF and PPS can reduce the surgical time. OLIF 5-1 can create more lordosis than TLIF 5-1 because of ACR. Thank you for your attention.
Thank you, Masato. I have one question which Arvind also has raised. In the cervical spine, the mobility is quite a lot. And
Yes.
even in the pictures that you showed, you could see there was so much of movement, intersegmental movement. How are you so confident to put in the next pedicle screw through a minimally invasive approach? That's one of the things that frightens me all the time.
Yes. Thank you for your good question. For upper cervical, we definitely choose C2 spinal process. It's a reference frame. And for lower cervical, we definitely choose C7 spinal process. And if the case is like spinal cord injury, you should put reference frame into the exactly the same vertebra of spinal process. So, but usually for degenerative disease, you don't have to so much afraid of the navigation accuracy. We will publish the case series. Now we have more than 10 cases to perform this kind of technique. Thank you for your question.
I would like to ask
David, you have something to tell about it?
I would like
Even in your region, there was so much of movement of the vertebra.
Yes.
yes,
Yeah.
sir.
So in our group in the cervical spine, one of the things that we do, you're absolutely right, Raja, that there's a lot of motion. So we check landmarks with a probe, and then one of the key items is no pressure on the tool. So we will use a drill and no downward force on it to minimize that distortion. And then if we have any question, we will place K-wires in the tracks and sometimes do a check spin to make sure that they're where we want. Obviously, what we're worried about is mostly a vertebral artery injury, and that you will know without a K-wire. But that no downward pressure is absolutely key to not distort your navigation technology.
I'd like to tell you something important. Nowadays, even in the United States, cervical pedicle screw is allowed by your FDA, right? This lateral approach, posterior approach is very safe because the screw angulation is quite different from normal angulation. So If you have a courage to perform our technique, please do it.
Yeah.
Thank
No, we do a lot of cervical pedicle screws navigated all the time,
Yes.
but it's just a minimally invasive technique. It worries me because there is so much of movement. So thank you, David. Thank you, Tanaka, for this great talks. This was a very good beginning. And now we go on to the debate. Sadish?
Yeah. So this today's debate is between the navigation and robotic for spine deformity surgery, and we have two eminent speakers from US. Professor Neil Anand will be talking for the navigation and robotics, and Professor Munish Gupta will be talking against navigation and robotics and his experience. So let's see. Over to you, Professor Neil Anand.
Thank you. I hope you can see my screen and
Yeah.
can you hear me? Anyway, greetings from
Yeah, go
the
ahead.
US. Good evening here and good morning to you, I guess. So my task is talk about robotic assist with navigation for adult spinal deformity. So I'm going to sort of quantify that. And these are my disclosures, none of them relevant here. But this is the guy I'm debating, who arguably is probably the best freehand pedicle screw surgeon that I know and I've seen. I've seen him operate a lot. He's a great surgeon, great guy. But I got 10 minutes now to convince him that robotics with navigation is something maybe even he might consider soon, if not in the future. So we're not talking of this. This is old robotics. The Renaissance spine assist, it had a track that moved up and down, and robotics was done that way. And yes, this was the way we got to where we are today. But we really need to talk about where we are today. It's a freehand robotic computer-assisted machine that just basically attaches to the side of your operating room table. It's not in your way. You operate exactly the same way, and everything is done out of the pre-operative CT scan. So hopefully I'm going to show you how novel that has become. And this is with navigation. So they both are incorporated into one module now. We have robotics with navigation. And that's what we're going to talk about. So this has gone out of the room. Just imagine that's not there. And that's what we're dealing with, a simple robot just attached to the table. Even Munish, I know today when he leaves Chicago or St. Louis, is not looking at a roadmap anymore. I know even he's not, if not, his kids are going to kill him. He's basically looking at GPS. He uses GPS to get there. And we've gone even beyond that. Today, our cars just drive by ourselves. We reached the point today, we got self-driving cars. The technology is there. We can get to where we want to. We can navigate to where we want to. So yes, technology is here and is here to stay, and it is coming, right? It's out there. And so what data do we have though? Just like we have very little data on self-driving cars being the best, you're going to see data as infancy in robotics. But there is data. This is Ramezi Lieberman, who probably is one of the pioneers of robotic instrumentation. This is his first 960 screws, 98.9% accuracy. So it's really good and pretty good compared to most other standards. This one is the one I'm talking about, robotics with navigation in the pediatric spine, 98.7% accuracy. So now you got the best of all worlds. We heard everything about navigation from Dave Pauly and Professor Tanaka, and now you add robotics to it, and you're now into a different dimension, and you take the best the world has to offer and put it all together, and we're starting to see that. Now, this case, Munish doesn't need it. He closes his eyes and he can put pedicle screws freehand, and I agree, he doesn't need a robot for this. I won't even ask him to do it. This guy can put a screw literally closing his eye. Even this case, he doesn't need it. He can put screws in. You'll have no problem getting it lined up, getting it perfectly done. And I'll even give him this case. He has no problem doing this freehand or whatever method he chooses to put his screws in and correct it. Though some of us may like some assist here. Not many. She's really good. But what about this one? 50-year-old female, wheelchair, T10 paraplegic. 30 years ago at a T10 to L2 fusion. 5 years getting worse and worse, cannot sit. She is actually a Hollywood music video dancer, believe it or not, on her wheelchair. And she's done a lot of really famous videos, by the way. And she's high functioning, getting worse, cannot even sit anymore, and got into a point where you look carefully, she actually developed a sarcojoint right below her fusion. She's got a 2-3 literal sarcojoint, and you can see that both on MRI and or CT scan. Massive fusion mass on the top, as you would expect, significantly decompensated, pelvic tilted around, cannot sit. So obviously, we're going to take care of her, right? And of course, we can do what we normally do. But here's where I thought this made a huge difference. Here's a bone density minus 2.9. We put her on parathyroid hormone analog to get her going. And as Professor Tanaka talked about, this has been a protocol for years where we do the laterals minimally invasively first, followed by screws. In her particular case, we did it all the same day just to get it all done with. So she got all the laterals, as you can see here, and then we did a A-lift in the lateral position, as you can see there, and that's all done. Now we go to the posterior. The key here was we were able to plan every single screw around the screws present before, and the hooks and the fusion mass. And that's what the robot does for you. This is a preoperative CT scan. So it's all planned. Forget the rods. You're going to see why that rod is not a good idea. But the screws, you can plan how to do it. You can plan the screws, the length, the dimensions. So now everybody knows what screw you're using. The robot has it all in the computer. And basically, you're able to plan this without opening anything up. And I'll show that in a minute. These are the time sequences I'm going to go through. At 1:39, the robot is scanning the surface. It does a scan surface. 1:41, we are navigating and assuring the navigation for the robot. 1:46, we're actually taking x-rays where you do a CT to fluoro registration. You take two views, AP and an oblique, that's it. This is then registered with the preoperative CT scan. And I want to walk you through this. Remember, this patient had a lateral now. This is a preoperative CT scan. It is still able to register segmentally bone to bone. The interbody did not make a difference. We were able to register CT to fluoro, looking at each segment individually. This is a game changer. So I don't need a spin in the OR anymore. I'm all going pre-op. So I got it. It's done. CT OR is registered. And we have gone on now. The first screw is in literally 20 minutes. Within 15 minutes, all my screws and rods are in. Within an hour and a half, the whole case is over. That's the incision. Only the skin opened. Nothing was stripped. Completely percutaneous. 2 hours skin to skin. We were done with this case. That's our post-op X-ray. Didn't touch the fusion mass. Didn't touch the previous screws. Everything carried out top to bottom in terms of doing it with the robotic assist. Here's a pre-op and post-ops. As you can see, and we got pretty good alignment there. And I think you'll see here is interesting that we were actually able to reduce her lordosis. She's a sitter. Remember, she doesn't walk. She sits. We didn't want to give her the hyperlordosis. Actually made it really well for her. And as far as I know, she's done really well now. She's 6 months out. And I think the key, this was the game changer for me. So much so, here's another one. 66-year-old flight attendant. Increasing back pain 3 years. Prior scoli, T2 to L2. Solid fusion, T2 to L2. Here we go again. We got all this degeneration lower down, massive fusion mass on top, screws, hooks to deal with, instruments to put in. Again, the robot was phenomenal in getting us around this hardware. We didn't have to take anything out, plan it out, put your screws in, line them up as you need to, get the perfect screws you need. The robot gets you to where you want to do it. You guide it down. And I'd say the learning curve is extremely little as opposed to navigation. I've never done a lot of navigation. The learning curve is really low with this, so whatever be it, it becomes very easy. My fellows are putting it first case and putting it in, and I can see them do it. The feedback from navigation, I know they got it right. I can see that years or post-op. Not completely MIS. We never opened anything, did not touch our previous hardware. Here she is. And you can see that, guess what? Even Muniz has to agree because this is from his website, the same case. He had to take out the entire hardware, open T2 to his pelvis, put a beautiful hardware in. Like I said, in his sleep, he can put screws. Great construct, but I'm sure he didn't get this done in 2 hours. And I'm sure if he had a robot right now with navigation, he would have loved it for this case. And not I would take all that hardware out. So this is where I think the role of robots with stealth navigation comes in. But not everybody can get in a tight space. It's hard. It's some people just can't do it. You can try as much as you can't. On the other side, you have to keep your eyes on what you're doing. If you're going to keep your eyes away from where you are, it's going to be a complete disaster. So you need to know where you are, what you're doing, and how you're going to use these tools to make it work for you for the right patient. Otherwise, you can expect disaster all the time. So I'll go back to the old thing. A fool is a fool who doesn't know to use his tool right, but it'll never make a bad surgeon good. But even Manish, the greatest surgeon he is, I think can become awesome. And that'll be his patient dancing away, next day poached up. Even Manish can go with robotics and make this happen. So it's intuitive and only a matter of time, I think. Driving cars are going to be here. Similarly, navigated spinal robotics. I think it's a platform for many great things to come. And I think we just got to judiciously use it. And I hope I'm convinced, Manish. Thank you.
Thank you, Anand. That was really great. Very convincing. We know you will make a very good pitch. But let's see what Munish has got to say. Munish?
Good evening, everybody. Good morning to you. I'm going to give you the case for the freehand technique. You have some great people giving you all the advice on how to use navigation and robotics. So the issues to discuss are general applicability, radiation, efficiency, accuracy, and costs. Can it be applied to every deformity? How much radiation are we exposing ourselves or our patients to? Is it efficient in terms of time in the operating room? And then how accurate is it and how different is it from other maneuvers such as robotics and CT navigation? And how expensive is it? So if you look at, there are three ways. One is freehand placement, and you can confirm with fluoroscopy or x-rays. Then you can use fluoroscopy to assist you in putting the pedicle screws. And then finally, there's placement of the screws with CT navigation. Well, if you look at the radiation exposure, as we've started using more and more x-rays, there's a 25-fold increase in prevalence of thyroid cancer amongst spine surgeons. This was reported at the SRS by Ted Wagner. And then if you look at the dose for the surgeon, it's minimal, 0.096 for fluoroscopically assisted placement in the AIS. But if you multiply by a lot of cases that you might do, it adds up. And you should have only maybe 50 millisieverts of radiation per year. The radiation to the patient is also increased. If you do a CT-based image guidance, it's like more than 7.29. And if you do that multiple times, let's say you change a screw or confirm a screw, so it's about 40 to 85-fold more than just fluoroscopy. And the breach rates were marginally decreased. It was more accurate. So their conclusions were basically that freehand pedicle screws has very low radiation exposure to the patient and the surgeon. And the freehand placement should be reserved by surgeons that are well versed in this technique. That means you should be good at it. And then finally, in cases of very abnormal anatomy, you might want to use fluoroscope or a CT navigation, whichever you know how to use. Well, you might say, well, I live in Kerala and I get 12 millisieverts anyway. Well, you don't want to add to that. So this is from just your environment, you can get radiation. There are some other studies that show that there's no benefit to the pedicle screw accuracy with navigation versus freehand technique in scoliosis. And what they found was their accuracy rate was pretty similar in terms of grading the screws on violation. And then the upper thoracic spine was the worst area for violation for navigated and freehand screws. But the only grade 3 violations were from the freehand screws. So navigation is more accurate. So the CT-based navigation was only slightly justified with mild or moderate scoliosis, and the research is needed to confirm the usefulness in complex spine, which I agree with. So the caveats are, I do not do many MIS cases except microdiscectomies. I do not use robots, and I've used navigation rarely. I use freehand techniques in most of my cases in thoracic, lumbar, and iliac screws. And then I've used fluoroscopy for placing pedicle screws when the landmarks are obliterated. So the tools needed are rongeur, high-speed burr, pedicle probe, a ball tip probe, and a power screwdriver. Simple stuff. And the preoperative planning is absolutely essential in my book. Plain radiographs, MRIs, if available, CT scans on very severe curves. And 3D models have added one more layer of pre-op planning for me. Study the pedicles pre-op. Use intraoperative radiographs or C-arm as needed. And if it does not look good or feel good, just leave the screw out. This is the technique I just want to show. By placing the points of fixation, a burr is used to decorticate the transverse process and make the entry point. The pedicle probe is then used to cannulate the pedicle, and then a ball tip probe is used to make sure that there's no violation of the pedicle walls. Bone wax can be used to stop the bleeding from the pedicle hole before insertion of the pedicle screws. Pedicle screws are then placed. Sometimes, in order to identify the landmarks, the facet joints have to be partially removed, and the pedicle entry point can be found, and a burr can be used to define the entry point, and the pedicle probe can then be used to find the pedicle screw tract, and the appropriate size and length of pedicle screws are then placed. So typical AIS case like this with a thoracic and lumbar curve, you can see that it's pretty rigid and rotated in the lumbar spine, not very flexible. This is the clinical photo of thoracic hump, lumbar hump. And then this is the X-ray, we measure everything. And then we look at the MRI scan if it's available to see where the cord lies and what the pedicles look like. And we measure them pre-op. As you can see, this is a pretty cortical pedicle here. And this is the lumbar spine. And we make a map before we go to the operating room of what the pedicle sizes could be. So this is the exposure. We always check the level. And then we do the releases and put the screws in. And if you're having trouble putting a screw in, you can feel through the releases, the pedicle, and then put the screw in. And we get an X-ray with the screws. And we also do EMG testing for the screws. And then we put the rods in to correct the spine. And then finally, the picture with the correction. And you can see the correction. And this is only 5 X-rays, no fluoro, no navigation. Some ridiculous cases, big curves. Same thing, do a CT scan on big curves. And then you can look at where the narrow pedicles are. And then you can plan if it's going to be outside the pedicle in or through the pedicle. And then we have this all available to us before we do the case. So this is the X-ray after, and you can see the correction of the cage and a pretty good result from a severe curve. Some really bizarre scenarios where you have very severe kyphosis. You do a CT scan, but I think a 3D model is even more beneficial in these cases, and everybody has 3D model capability now. So this really helps plan and execute the surgery. You can see the result here. Even worse, big curves, put in halo traction and then did the fusion. And we did that. We did the CT scan and 3D model before we did the vertebral column resection on that patient. Let's say you're doing this curve and some of the pedicles are small and you can't get them. So Don't forget the sublaminar wires. You can use sublaminar wires in these cases, and it gives you a pretty good result, as you can see here. You can see the cosmetic deformity as well. When to use navigation in my book, if you have a case like this where you have a fused spine, broken rod, really falling off the top, the CT scan is helpful, but for me, the 3D model is quite helpful. We can actually make the rods in different colors so they're distinguished from the bones. And you can plan out your vertebral column resection. You can mark the vertebrae you want to take out ahead of time. So we used a two-stage approach where we put the screws in under navigation where the fused spine was, and there were no landmarks to follow. And then that was the first stage, and then we came back and did the vertebral column resection at the second stage, and you can see the result there. So why use freehand technique? It requires little equipment. It's very inexpensive compared to navigation and robots. It can be taught easily to residents and fellows. All our fellows are pretty good at it by the time they leave our fellowship. There's no extra radiation exposure to you or the patient, and there's no extra time needed to set up the navigation and robots. That seems to be the longest time sometimes. And it can be applied to majority of the open cases. And if you don't have a lot of money in a hospital, you might want to spend it on patients rather than equipment. Thank you so much.
Thank you, Munish. Always impressed with the cases that you show. But unfortunately, God created only few, I think only one Munish around the world. I was going to say few, but it's fantastic. Neil, do you have to say a 1-minute rebuttal, and then I'll come back to Munish?
It's hard to argue with Munish's talent, and I will not even go there. But I think not everybody can be Munish, and I think when it comes to a difficult case, I will give offhand that for a normal, regular case, you probably do not need a robot or navigation for any regular spinal deformity surgery. But I think it's the difficult cases that make the difference, and it's a huge help. And now with robotics, with the navigation, I think it's truly a game changer today, as opposed to just navigation or just a robot as it was before. That combination today to me is huge for two reasons. One, no intra-op CT, so less radiation. You're using the same pre-op CT that I would have got anyway to do all the planning. And the radiation dose to the patient and you is now down. It's actually one step further. And to me, I think it's a platform for much greater things to come. So it's pretty exciting where we are.
Okay. So Neil, just one question. Have you had mishaps with this? Because there is a lot of question. No doubt robot is good for ordinary cases, but there is a lot of apprehension amongst surgeons that robot can have a major mishap in cases with gross deformities. So do you have a full-fledged study, a prospective trial on robot on gross deformities?
Full disclosure, I've only done 15 cases with the robot and navigation put together. The navigation thing was great because now you could see. I was actually pretty reluctant to do robots by itself in major deformity, but you have no idea where the robot's taking you MIS. So I actually would not do it. I only did that open where I could see the landmark. So I sort of gauge, okay, the robot's taking me the right place, right? Now with navigation, I'm comfortable doing MIS. But I got that added feedback. But you're right, is there going to be a mishap? So at some point there is. Luckily, they haven't added. I really think the robot with the navigation has changed. You can on the fly change your orientation on the computer to redirect your screw today. So let's say you did have a bad screw and you felt it's wrong. You can actually take it out right there and then adjust on the computer, have the robot shoot it again. And we did have that twice. Twice we had to reorient the screw. So the technology has evolved immensely today. So I think we're talking of robot, to me, I'm talking of robots with the navigation, the latest one we have today, as opposed to, I think you guys have Renaissance, and I'm not sure Masorex and other have come, but they're getting there. I think it's there.
Okay. To Munish, one question. Munish, at any point of time, even in the worst cases, do you ever have felt oh, I wish I had a robot or a navigation to help me.
Well,
Many pedicle screws misdirected screws, and you lost the screws. And have you ever thought, if only I had navigation?
well, first of all, I want to thank you guys for putting this together, and it's really nice to see your faces. I've missed you guys a lot. That's number one. Number two, I think we pretty much agree with everything we're saying. We have the same common theme, and I will answer your question in a minute. I just don't want people to become spine surgeons and not know freehand technique and go to the operating room and say, if you don't have computer navigation robot, I can't do the case. That's number one. I think you have to learn that. Number two, navigation, robotics, all these things are fantastic because they're going to add to our armamentarium. And with technology advancing, they'll get cheaper. So it's not much of a burden. If you're in a small town in India and you can't afford it, you don't feel like a third-class citizen. And the last thing I would like to say is that, yes, of course, there are cases where you think you might need it, but I have found that when I do the releases and I can feel the pedicle from the inside, it's pretty safe. And I'm not afraid to put a sublaminar wire where I can't put a screw. You don't have to have a screw in every pedicle.
Thank you, Munish. I would like to thank Sailesh. I don't want to leave the first session late. And it's been really great having the best of the faculty across the world. Sailesh said there are 2 surgeons from US, but I would like to point out that Munish and Neil are from India, not 2 surgeons from the US. So David, Masato, Munish, and Neil, it's a great pleasure to have you. You're great friends of India and ASSI, and it was a wonderful way to start. So thank you, Gautam. Thank you, Ankur. Thank you, Sailesh, and we leave. Bye-bye.
Thank you, everyone. It was a great session. Thank you all. Thank you.
I thank the moderators and the faculty.